So it's my pleasure to introduce our next speaker. It's Shelley Hwang. She's Chief of Breast Surgery at Duke University, and her talk is going to be about estimating the magnitude of clinical benefit of local therapy in patients with DCIS.
Thank you very much for the moderators of this session and the conference organizers for really the delight of being here at this very important meeting. Today, I've been charged with talking about estimating the magnitude of clinical benefit of local therapy in patients with DCIS. So I'll be talking about radiation and then, importantly, what the role of surgery is in treatment. And I just wanted to make sure we're all centered at the very beginning about why we treat DCIS. We talk about it, we treat it, we diagnose it, but what is the goal of treatment? And I would say we have one, and that is to prevent mortality from invasive breast cancer. So as we go along this talk, I'd like for you to keep in mind that things like recurrence risk are very important, but really the most important goal of treating DCIS is to prevent mortality from breast cancer. So I'll repeat some of the lessons that Fraser shared with you already, but I just wanted to make the point that the DCI incidence parallels the number of mammogram machines, and you'll see this in all countries that have started breast cancer screening. And in the 1980s, before we had widespread mammographic screening, DCIS was hardly ever diagnosed, and now there's been a 4- to 5-fold increase in the diagnosis of DCIS, where now about 1 in 1,000 mammograms results in this diagnosis. Now, we didn't intend to find DCIS. It's an unintended consequence of increased screening where these white dots on a mammogram were picked up, and that is really the first indication that a woman has that she has a diagnosis of DCIS. And Fraser did a good job explaining that the whole progression pathway of epithelial cells from normal duct lumen way on the left to invasive carcinoma in the right is a progression pathway. It's a spectrum of pathologic changes. And as some of the studies have shown, there's a blurring of lines between when proliferation becomes atypia, when atypia becomes DCIS, and indeed when DCIS is considered to be invasive cancer. So DCIS is considered a precancer or pre-invasive cancer. In the United States, we have about 60,000 new cases annually. And what's very interesting is that in autopsy series, the women who died of non-breast cancer-related causes, the prevalence of DCIS in a patient not known to have had breast cancer in life is about 10%. So certainly not as high as undiagnosed prostate cancer, but certainly a significant number. DCIS is considered a non-obligate precursor, so we know that there's a relationship between DCIS and invasive cancer, but the rate and the likelihood of progression are really not known for an individual patient. So I'll start off with spending a few minutes talking about the benefit of adjuvant radiation, because that is, of course, one of the local treatments that we use very commonly for treatment of DCIS. And these are data that we published a few years ago looking at SEER, which is a national cancer registry in the United States of patients diagnosed with DCIS from 1991 to 2010. And the dotted line here that I highlighted in red indicates patients undergoing lumpectomy with radiation. So in the United States, about 50% of women who are diagnosed with DCIS undergo lumpectomy and radiation. So it's a very important part of standard treatment for DCIS. Now, at the time that this was published in 2010, the Early Breast Cancer Trialists Collaborative Group did a very nice overview of the 4 prospective randomized trials of women diagnosed with DCIS and treated either with lumpectomy alone or lumpectomy with radiation. And you can see here yourself that the absolute reduction in ipsilateral breast tumor rate was 15%, so that's the absolute reduction, but that translates to about a 50% proportional reduction in ipsilateral events with radiation following lumpectomy. Now, this was for all events, not just invasive cancer. But the absolute magnitude of the reduction was dependent on the baseline risk of recurrence, as Dr. Simmons alluded to, and the benefit was independent of the patient's age, tumor size, or margin status. And when we look at it another way, when we look at the lowest risk group of patients with DCIS, so looking at patients who are grade 1 or 2, who had tumors less than 2.5 centimeters, and widely excised margins with lumpectomy where the margins were 3 millimeters or greater, and we randomized them to either lumpectomy or lumpectomy with radiation. There is a significant difference in local failure in women who had lumpectomy alone, shown here in blue, or lumpectomy with radiation in yellow. And even in this very low-risk population, at 12 years of median follow-up, this was last reported at San Antonio just a few months back, the patients who underwent lumpectomy and radiation in this very low-risk group had a 2.8% local recurrence rate with lumpectomy and radiation, and 11.4% recurrence rate in the observation arm with lumpectomy alone. And the recurrence risk translated to about 1% per year in patients who did not have radiation, even in this very low-risk group. Now, Fraser showed this already. The 12-gene recurrence score is a molecular prognostic marker that separates patients with DCIS into 3 risk groups, low, intermediate, or high. It's based on 12 genes. And this has been validated in both a clinical trial as well as in a population-based Ontario DCIS cohort. And then there's also a second marker called the Prelude DX, which Fraser also showed you, that separates patients into a low versus a high risk. And the only reason I want to show you these two markers is that these are the 2 markers that are currently available for ordering in the United States. And this helps to stratify risk for patients with newly diagnosed DCIS, such as the patients who are on the higher end of the spectrum, higher risk for recurrence, are the ones who are more likely to benefit from adjuvant radiation therapy. So I'll switch gears a little bit now and talk about why we operate on patients with DCIS. And I'll draw your attention to the left side of the panel. And this shows very briefly that the light gray is patients who have no surgery. So you can see for patients who are diagnosed with DCIS, there are very few patients who have no surgery currently in the United States. The dark gray and the light blue are patients who have undergone breast-conserving surgery or a mastectomy, and the purple represents patients who've undergone bilateral mastectomy. So the take-home message from this is that just about everyone with DCIS ends up undergoing some type of surgery for their disease. And I would be remiss if I didn't include this slide, which is that there are guidelines for patients undergoing surgery for how large the margins need to be. So this was a consensus panel that convened in 2016, and the ASTRO guidelines for DCIS indicate that if a patient undergoes surgery for DCIS, the margin needs to be 2 millimeters, but distances above 2 millimeters don't reduce the future risk of developing a recurrence in women who undergo lumpectomy and radiation. So again, this is in patients who are undergoing lumpectomy and radiation, and there's limited data to support this margin guideline in patients who are not undergoing radiation, who have a large DCIS or multifocal DCIS, or age less than 40, because these were the subgroups that were not very well represented in the data that we reviewed. So if patients undergo surgery and have a lumpectomy and planned radiation, the recommended margin width is 2 millimeters in these patients. Now, what happens when we treat patients with all the surgery and radiation that we do? And this is just in all patients looking at the overall survival on the left and breast cancer-specific survival on the right. And you can see that the only difference between the lumpectomy and mastectomy and lumpectomy and radiation groups is that the overall survival is different between these 3 treatment groups, indicating a treatment bias rather than an impact of surgery itself. Because when we look at breast cancer survival specifically, there really is no significant difference between the mastectomy group, the lumpectomy group, or patients who underwent lumpectomy and radiation. So taking it a step farther, given that everyone does so well and that the choice of treatment or surgery doesn't appear to matter, what happens if you don't operate on patients who have DCIS? Now, it's very hard to get these estimates because, of course, I told you earlier, in the United States and certainly most countries that diagnose a lot of DCIS, the vast majority of patients undergo surgery. So it's very hard to get data on patients who don't undergo surgery. But nevertheless, in this large prospective registry in the United States from 1988 to 2011. There were over 1,000 women who did not have surgery for their DCIS. And when you look at the entire group, the group that had surgery, which is the solid line, separates from the group that did not have surgery, and that's the dotted line. But I'll draw your attention to the grade 1 DCIS, where the patients who had surgery versus those who did not have surgery had the same overall breast cancer specific survival. And this really provides some rationale for considering not doing anything other than close monitoring for these patients with the lowest risk disease. Now, we looked a little bit more into this cohort, and we were able to see that we can start separating out the high versus low risk patients, even though the numbers were very small and we did not have statistical significance in some of these comparisons. But overall, if you pick the lowest risk group of patients who were ERPR positive and had grade 1 to 2 DCIS, their 10-year risk of developing an ipsilateral cancer in the breast that had DCIS is only about 1 to 2% per year. Now compare that to a disease that we don't routinely manage with surgery and radiation, and that's LCIS. This is a very nice cohort study published from the Memorial Group in 2015. And remember, this is a disease that's now not even considered to be a cancer. And these patients also had about a 1 to 2% annual risk of cancer. And then taking it a step farther and looking at patients who have ADH, this cohort was published in 2015, and when you look at the ADH cohort, and this included about half patients who had ADH and half who had ALH, this also confers about a 1 to 2% annual risk of cancer. Again, this is not a disease that we currently treat like a cancer. We don't do surgery and radiate these patients like a cancer. But compared to low-grade DCIS, this is about the same sort of risk of 1 to 2% annual risk of development of cancer. So if we don't operate on these patients, is there a role for systemic therapy? The next speaker is going to talk exclusively about systemic therapy, but I just wanted to include this study, which we presented about a year ago. And this is a study of neoadjuvant treatment with letrozole in patients with ER-positive DCIS. We took an MRI at baseline and an MRI after 6 months of letrozole therapy. And you can see some pretty nice changes in patients who are treated with preoperative letrozole, and compared to baseline, women at 6 months had a very nice response in most cases to the enhancement in the DCIS that we saw. But what I really wanted to say was that in these patients who were treated with preoperative letrozole, on average, they had about a 30% reduction in the enhancement of DCIS on MRI, and by 6 months, there was almost a 40% reduction in the volume of enhancement. And when we operated on these patients, 6 patients, or 9% of the cohort, had a pathologic complete CR, indicating that preoperative endocrine therapy, or endocrine therapy given almost as a preventive agent, as we do in LCIS or ADH, may be able to eradicate at least low-grade DCIS or intermediate grade in some patients. So I'm just going to conclude by saying a few words about the rationale for not potentially operating on these patients, and I'll describe a little bit more the ongoing studies that are open and accruing now in patients who have low-risk DCIS. And I'll just walk you through this model, this conceptual model that we developed based on published data. And the dark black line here demonstrates the cumulative mortality, all-cause mortality versus breast cancer-specific mortality of patients undergoing surveillance. So if we did not operate on patients, the black line indicates the breast cancer-specific mortality of women who are diagnosed with DCIS. The gray represents a 25% confidence interval. The red line and the confidence interval for that represents the mortality of patients undergoing usual care, so surgery, radiation, all the things we usually do for women with DCIS. And the blue here represents the competing mortality risk. And when you start off with a woman who's age 40 at diagnosis, which this represents, the difference between active surveillance mortality and usual care mortality, so surgery, is about 2.6% at 10 years. Now, I would argue that's a pretty large difference between surveillance versus usual care, so I think especially in this younger patient population, intervention can definitely be justified. Now, look what happens as a patient gets older at the age of diagnosis. The difference between the monitored group, surveillance group, versus the surgery group starts to narrow. And the competing causes of mortality represented in blue starts to go up. So that difference between patients who have surgery and don't have surgery narrows now to 1.5%. And then in the women who are age 70 or older at diagnosis, that difference between surveillance and usual care is now about 0.2%. It's not significantly different because now the overwhelming cause of mortality in women who are diagnosed with DCIS are the other competing causes of mortality. So I think that really sets the stage for considering which women with low-risk DCIS may potentially benefit from not having surgery. So I would argue that patients who have newly diagnosed low-risk DCIS, especially in those women who are older than 40, are candidates for such an approach. And the primary outcome for all of these trials that are comparing active surveillance or monitoring to surgery for low-risk DCIS, the primary outcome is development of invasive cancer. Because remember, I told you at the beginning, that's really the only reason that we would be interested in operating on patients with DCIS. All these trials are a one-to-one randomization between usual care and active surveillance. And the studies require annual or biannual mammography, and I'll show you the difference in just a second. Obviously, patients will not continue to be monitored if they develop cancer when they're on surveillance, and there's intervention if there's any evidence of progression to invasive cancer. And this is just the trial schema for the COMET study. This is a randomization of patients who have low-risk DCIS between guideline concordant care, so usual care, versus active surveillance, which is monitoring. And the endpoints of this study will be to look at quality of life, some psychosocial outcomes, body image, as well as the primary endpoint of development of invasive cancer. So there are 3 randomized trials for low-risk DCIS. The LAURAS trial is open in the UK, the COMET trial in the US, the LORD trial in Europe, led by colleagues at the NKI. And all these trials are very similar in their approach. They differ a little bit in terms of age of eligibility and whether endocrine therapy is allowed. So COMET is the only trial where endocrine therapy is allowed for patients who are on surveillance. Between these 3 trials, we will have about 3,000 women who are randomized to an observation type of approach that we use for LCIS and ADH versus a surgical approach, which I would argue really needs to be relegated to patients who are diagnosed with invasive cancer. So in summary, surgery is currently the mainstay of therapy for DCIS. It yields excellent outcomes, as I've shown you. Adjuvant therapies show proportional benefit for radiation, so about a 50% reduction in events with radiation. But there are trials that are in progress to determine whether maybe the lowest risk DCIS may be very appropriately and safely managed just as we do in the prevention setting for LCIS and ADH, especially relevant because a lot of times the pathologists are not in agreement over whether someone has ADH or low-grade DCIS. And so I think the generally excellent prognosis in patients who have low-risk DCIS is really an opportunity to right-size the treatment. And by that I mean make sure we include radiation as part of treatment for those at highest risk and consider de-escalation, including omission of surgery for those at lowest risk. And I would remind everyone that this is really the goal of personalized medicine, which is to classify individuals into subpopulations instead of treating everyone with the same diagnosis in a uniform way. And then what that allows us to do is, as we get better at stratifying risk with some of the tools that Dr. Simmons has mentioned already, preventive or therapeutic interventions can be concentrated on those who will benefit, sparing the expense and side effects for those women who will not benefit from such an intervention. So I'd like to acknowledge my team, all the generous funders who have gone into funding the trial and the research in my lab. And most of all, I'd like to thank the conference organizers for the honor of being able to present to you here today. Thank you.
Thank you for this nice overview. So we have time for one question. Yeah, I see here at microphone 2.
Yes, I'm Maria João Cardoso from Portugal, and love your presentation.
No, thank you.
I think one of the most important things in DCIS is the transmission of risk to patients, because we usually use our statistics to explain, and that's not the case to do. And I think we should maybe try another approach, like micromorts or something, because I think that's the most difficult thing to do, is because they don't understand the difference between DCIS and invasive.
Yes.
What's your approach usually with patients? Do you simply, because it's really difficult?
Yes, I agree with you very much, and I think most of us are seeing these patients in a very busy clinic, and you certainly don't have time to spend an hour talking to them about statistics, and that's not what patients want anyway. So a lot of our research involves risk communication, and so we've developed a decision support tool to walk patients through. It's an interactive tool, and I'd be happy to show you after this session. We've also spent quite a bit of time trying to develop videos and educational materials for patients, either as part of the prospective randomized studies or on their own. But I would say just in general, when I see a new patient in the clinic, I use a little table that I fill out for patients. And every column is a different kind of treatment. So endocrine therapy alone, lumpectomy with radiation, mastectomy. I walk through all of those, and I kind of synthesize the data from all of these different trials and try to give women an idea of what their recurrence risk is, and most importantly, what their likelihood of invasive cancer and mortality is. I think we always forget to tell patients that. But as I said with my very first slide, that's really what we're trying to accomplish. We're not trying to get rid of these white dots on a mammogram. We're trying to save lives. And so I think when women see that those mortality risks are not that different, hardly different at all, even if you do surveillance in some cases, I feel that that's a good visual for people to look at.
Thank you.
Thank you for the question.
Okay. Thank you.